talk about is Streptococcus agalactiae, or sometimes they call it group B Strep. So remember, Strep pyogenes is group A strep, and that classification has to do with the antigens it has on the surface. So as you might imagine, by microscopy, you can't really tell them apart. They're gram-positive rods, they're Streptococcus. So finding gram-positive rods in a chain doesn't necessarily let you know that it is this particular species. Strep agalactiae is also beta hemolytic, so it will do complete digestion of the red blood cells on a blood agar plate. You would see a clear zone around the bacteria. And in a couple of weeks in lab, so next week we'll be doing staphylococcal species. The week after that, we'll be doing streptococcal species. So you'll actually get a chance to work with some of these and see how they look in culture and do some of the testing that you might do in a lab setting. How do we tell it apart? So how do I know the difference if I'm the clinician between group A and group B strep? There are a number of different ways. You can look for the cell wall antigens. You can look for the polysaccharide capsule. They have different polysaccharides that make up part of the capsule. And they have different cell surface proteins. And remember that capsule is a really important virulence factor because it impedes phagocytosis, and it also can impede deposition of complement. So having a capsule is great because it's helpful for immune evasion, and it also helps the bacteria to adhere to the host. One of the other hints, maybe if you're the clinician, that you might be looking at group B strep versus group A strep is where you find it. So where did we commonly see strep pyogenes or group A strep? Upper respiratory tract. Where else? I showed you some real gnarly pictures last Friday. In the muscle, right? The necrotizing fasciitis. With group B strep, where you're actually going to be more likely to find it is either the GI tract or the genital urinary tract. And I mean, it's not rare, right? It's relatively common in more individuals than just pregnant women, but pregnant women are the most tested population for this infection. I'll tell you why in just a minute. But so those of you who might be going into, OB type specialty, or if you get a sample from an OB looking for group B strep, it's important because it can affect the neonate. But it's estimated that anywhere from 10 to 30% of pregnant women are colonized by the bacterium, and it's not causing a problem. You wouldn't know. Where it becomes a problem is when an infant is born to a woman who is positive for group B strep. So it's estimated that about 60% of infants delivered vaginally to a woman who's positive for group B strep will also be colonized with the bacterium. Yes?
As you said, it's mostly in pregnant women. Does pregnancy cause that? Or?
No, so it's not necessarily that the infection is more common in pregnant women. That's just the population we test most frequently because of the risk to the infant. I think if we tested everybody, we probably would see similar rates of carriage just in the general population. Mm-hmm. It's not that pregnancy predisposes you, but because of the risk to the infant, that's why we test that population specifically. Yeah, that's a good question. But I would be willing to bet that similar colonization rates in men, women, not pregnant women, pregnant women. Yes?
So you said that it affects 60% of the infants when they're born vaginally.
Mm-hmm.
So if the mother were to test positive for strep B, would they be able to resort to a different...
Like a C-section?
Yeah. Would that prevent...
So sometimes when mothers have different types of infections, it could be group B strep, it could be a herpes outbreak, it could be whatever, you can opt for the C-section to reduce the risk of transmission. For group B strep, what they tend to do is just prescribe them other antibiotics. So they'll do the testing. I don't remember when I got tested, but in the 3rd trimester, so not like right before delivery, but close enough that they could prescribe the antibiotics and help you clear the infection beforehand. And even if they maybe couldn't clear the infection, they would know to treat the infant right away. Yeah. So it would be for something like strep, which is normally, there are some antibiotics that work pretty well. That would be what the doctor would do, would be to prescribe antibiotics. And so we worry about this in infants because we worry about everything in infants. Infants don't have a very good immune system. They're very susceptible to infection. When infants develop symptoms within 7 days of birth, they call that early onset neonatal disease. It can be bacteremia, so the bacteria in the bloodstream, pneumonia, meningitis. The mortality rate can hover around 5%, so about 5% of infants who develop the early onset disease will die. And we may have a good proportion that live. I know it sounds like, well, 5%, that's not great, but 95% live. But especially if they've developed meningitis, that can lead to neurological complications, including blindness, deafness, developmental delays, etc. If they develop disease more than 7 days after birth, that's considered to be late onset. And generally late onset is characterized by bacteremia with meningitis. We don't usually see it as pneumonia. And the risk would be the same, right? Maybe the infection will clear, but there's a big risk for neurological complications. Babies are just so sensitive. So if they have meningitis, if they have the inflammation surrounding the brain, that can cause a lot of complications. So when a woman does have this infection, especially during pregnancy, right after birth, that can predispose her to some significant complications as well. So let's say she has group B strep, perhaps she wasn't diagnosed, or she wasn't treated, or the treatment didn't work, whatever. She's delivered the child who had a 60% risk of developing the infection, but now she has a risk of developing infections from this bacterium because birth is a traumatic process. The bacteria can get in and cause infection in the endometrium. If there were any wounds, like tearing during childbirth, you could get an infection there. Women who have an epidural tend to get a catheter, far more likely to develop a urinary tract infection when you have a catheter. So this is more in like the immediate postpartum period, there's a higher risk for women who are pregnant. So those are your two major groups of individuals who might experience symptoms from group B strep, your neonates and your immediate postpartum patients. Other patients who tend to experience symptoms are going to be immune compromised, which is why we say there's this kind of range of people who might be colonized but not show symptoms because their immune system can kind of clear things up. But in your patients who are immune compromised, and we'll see this throughout the term, if you're immune compromised, you're far more likely to develop symptoms. And in those patients, we could see things like bacteremia, it gets in the bloodstream, pneumonia, bone and joint infections, and skin and soft tissue infections. So it can look a lot more invasive, more like the group A strep. And again, if you find a patient that is not a neonate and not a postpartum woman, and you see symptoms by group B strep, you might wonder maybe they have something going on with their immune system. It actually gets its name, the Latin name, agalactiae, because it's a cause of infection in dairy cattle. So it causes mastitis, infection in the udders. They don't produce milk, agalactiae, no milk. And it can, weirdly enough, can also cause epidemics in farmed fish. So in the aquaculture, instead of agriculture, aquaculture. So in the fish farms, it can cause infection. So here's a case study of group B strep in a neonate. So this is late onset group B strep in a neonate. An infant male weighing 3.4 kilograms, just over 7 pounds-ish. So healthy baby, delivered spontaneously at term, so 40 weeks. Physical exams were normal during the first week of life. Remember, late onset is after 7 days. However, the child started feeding irregularly during the second week. Day 13 was admitted to the hospital with generalized seizures. So that's going to be indicative of what? When you're starting to see seizures. The neurologic, the meningitis. A small amount of cloudy CSF was collected by lumbar puncture. So that's when they actually put a needle directly in the spinal column to get some of the cerebrospinal fluid out. Bacterial, fungal, parasite infections, you'll see cloudy CSF. With viruses, it can still be clear sometimes. So cloudy is never good. That does mean there's an infection. They isolated group B strep. Despite prompt initiation of therapy, the baby developed hydrocephalus, like fluid in the brain, necessitating implantation of a shunt. So when you have fluid buildup on the brain, they literally will drill a hole in there and put in a shunt, like a tube, to let that fluid drain out. The infant was discharged at age 3.5 months. So admitted at day 13, so let's be generous, 2 weeks, a 2-week-old baby, went home 3 months later with retardation of psychomotor development. It's really hard to tell what's wrong with the baby when they're that little because they just kind of lay there. But there are some things they start to do, right? They can start to smile. They can start to look like they're going to roll. If you put them on their stomach, they try to get off their stomach. So that's what the delays would probably be. So those of you thinking about pediatrics, maybe. So this shows how neonatal meningitis can cause symptoms that can be more permanent. So the baby was in the hospital for 3 months and still had psychomotor development issues. So it's important for you to look into that. It's possible. I think it would really depend on the infant itself, like what reflexes might be affected. Again, it's hard to tell at that age. I'm trying to remember, when I took my kids to the pediatrician when they were that old, the reflexes they're looking for are will they make eye contact? Will they look like they're starting to roll? So it's hard at that age, but as they get older, you're going to see more and more defects. They may not sit up, they may not be able to hold their heads up without support, and then eventually you'll have speech delays. Yeah. So again, yes. No.
It's because since if the mom is infected, it automatically goes to the baby, right?
It's a 60% chance if the mother is infected that the neonate or the infant will be infected during birth. Yeah. So it would be diagnosed. You could do antigen testing or PCR testing. And again, during pregnancy, this is why there's lots of reasons. One reason it's recommended that pregnant women do actually seek medical care. You don't have to do the whole wild birth thing. Please do visit a doctor because they can do chemoprophylaxis. It's a fancy way of saying they're going to give you antibiotics before you have the baby. If you're at high risk of transmitting the infection. Or basically, if you're planning on a vaginal delivery and you have group B strep, you should probably get on some antibiotics. So any other questions about group B strep? All right. So our last streptococcal species is Streptococcus pneumoniae. So just based on the species name, what type of infection do you think this one might cause? Pneumonia. Yeah, this is going to be your pretty common respiratory streptococcal species. So it does have a capsule. It can be variable, depends on the strain, whether or not it's alpha or beta hemolytic. So you may see that complete lysis of the red blood cells, or you might see the incomplete lysis, which hopefully you remember from bacteriology or microbiology. It's kind of a greenish halo around the colony. They produce toxins that will break down hemoglobin. So that's how you get the hemolysis. And also that can destroy ciliated cells. So remember, up your respiratory tract is that mucociliary escalator that's supposed to help clear out infection, get rid of junk that's gotten into your respiratory tract. So this toxin can kill those cells, so you get the buildup of mucus in the lungs, and it can destroy the phagocytic cells like the alveolar macrophages. Okay, so you can see like the different hemolysis patterns here, where some of them can do the complete hemolysis. This picture isn't like, they never show up as nice as I want them to on the screen, but you can get kind of a greenish tint, or you may not even see, here's where it has like very little hemolysis, but there is just a little bit surrounding the colony. So it's tricky because you can't necessarily say which strep species it is just by looking at it on a blood agar plate. As you've already discussed, right? You've already decided this is a pathogen of the respiratory tract. But it's actually a pretty common resident of the throat and nasopharynx. So we will be doing an experiment in the lab in the next few weeks where you're going to swab your mouth and throat. Somebody will swab it for you. If you're anything like me and you throw up at the drop of a hat, do not volunteer to be the one who gets swabbed. So, because it's going to go in there and swab your tonsil. Some of you may have this bacterium that pops up, and we'll be looking for it because we know it's a common resident of the nose and throat. It also produces an enzyme called IgA protease. I think this is the first time we've seen IgA protease as a virulence factor. So it's helpful for immune evasion. What do you think it does specifically? It degrades IgA. And why is IgA important? Exactly. IgA is the major antibody in the mucosal system. So this bacterium has an enzyme to break that antibody down, and that's supposed to be the antibody that's the major protective one in that area. Again, it causes pneumonia. The species name kind of gives that one away. With a patient, you'll have what's called a productive cough. So if a patient comes in and they have a cough, they'll classify it in two different ways, a productive versus a non-productive. A productive cough, it says right here, produces sputum. You're going to have mucus and phlegm come up when that person is coughing. A non-productive cough is more of a dry cough. There won't be chunks of mucus that come out. With strep pneumoniae, that mucus can be blood tinged. There can be blood in there because it does possess those toxins that can destroy the cells of the respiratory tract. So that can cause that tissue damage, which can lead to bleeding, and as you might imagine, pain. So this will be painful for your patient. And it's generally associated with aspiration or lobar pneumonia, where sometimes it's just in a particular part of the lung, maybe not spread out through the whole lung. Those of you interested in pediatrics or who may have children or do have children, this is also one of the most common causes of otitis media, middle ear infections, and sinus infections. So because it's a normal resident of the nasopharynx, it can get into the sinuses and cause infection if it overgrows. But we have these little tubes that connect our ears to our sinuses, these eustachian tubes. And as you might imagine, children are very small. They have very small eustachian tubes. If they get swollen at all from a viral infection, from allergies, from a different kind of infection, they can back up and cause the bacteria to just grow and grow and grow in the middle ear. what they'll generally do for children who are prone to those types of infections. So you can see here the bulging eardrum with the infection behind it. Often they'll put tubes in the ears so that when the infection does happen, because you can't really stop that infection from happening, the infectious material can drain out of the ear instead of causing the eardrum to burst. Because that's what will happen otherwise. The infection will build up and build up and build up until the eardrum bursts. And that can, one, be very, very painful, but two, if it happens more frequently, can cause permanent hearing damage. So with children, you really want to take care of these middle ear infections. Also, if left untreated, in some patients, these structures are so close to the brain, you can get meningitis, or if there's head trauma that might create a wound where the bacteria have access to get into the skull. And that's, here you have, again, hard to see the colors, but if you have the dura mater being pulled back here, they're trying to show this has meningitis, there's fluid buildup, multiple small hemorrhages, and greenish pus covering the brain. So when the bacteria get in there, that's what they can do. And this is a picture from an autopsy of a patient who died of meningitis. Okay. Bacteremia can also happen. So then you have, the bacteria floating around the body. They can overstimulate the immune system. You can have that septic shock. So it's really important to treat these infections, even though, it sounds like, oh, every kid gets an ear infection. It's important to treat them. And as an adult, if you develop pneumonia, it's really important to get that taken care of because it can get much worse. So here's a case of pneumonia. This is a 68-year-old woman who was in good health until 3 days before hospitalization. She developed fever, chills, weakness, and a productive cough with chest pain. So the pleura is like the cavity surrounding the lungs. On admission, she had a fever, elevated heart rate, elevated breathing rate, and she was in moderate respiratory distress. So she was having trouble breathing, and so she was breathing faster, trying to get more air, so she was in distress. She had low white blood cell count, anemia, so low red blood cell count, and she was in acute renal failure. Chest x-ray demonstrated infiltrates in the right and left lower lobes, so in the lobes, instead of like diffuse through the whole lungs and a part of the lungs, and what are called pleural effusions. So that's basically when fluid builds up in the pleural cavity surrounding the lungs and kind of, almost like compresses the lungs. So you have less volume of air you can take in because there's fluid building up outside the lungs. I don't have pneumonia, I promise. That's not why I was coughing. Therapy with fluoroquinolone was initiated, blood and respiratory cultures, so it's in the blood, which is not surprising because this patient did have a fever, so it's likely that we're seeing this maybe go a little bit more systemic. Positive for strep pneumoniae. Additional tests revealed that the patient had multiple myeloma. This is a cancer patient who was previously unaware that she had cancer. The patient's infection resolved with a 14-day course of antibiotics. She illustrates the typical picture of pneumococcal. So that's what they'll call Streptococcus pneumoniae. They'll sometimes call it pneumococcus. If you hear that, it's the same thing. Lobar pneumonia and the increased susceptibility to infection in patients with defects in their ability to clear encapsulated organisms. So blood cancers make it difficult. They suppress the immune system. So she didn't know that she had cancer. She was diagnosed with cancer because she had this infection. So again, that's something that you can look out for. Why would an otherwise healthy person develop this infection? Well, she wasn't otherwise healthy. Okay. If you do microscopy of samples from areas that should be normally protected, meaning normally sterile, and you see Streptococcus, that's a good sign. So for example, the CSF. And so this is one of the things that I'll ask you to think about as we learn about more organisms, as we progress through the term. You'll see a lot of these organisms cause the same symptoms. Meningitis, we're gonna talk about meningitis. Bacterial, lots of different bacteria. Fungi, viral. amoebic. How do you tell the difference? Do you have time to try to culture them? Do your PCR, right? Do all these tests that might take days and days? No, your patient could die. Sometimes you literally have a couple hours to try to figure out what it is. So if you do a lumbar puncture and you see gram-positive coccus, because you know how to do a gram stain, that's why I make you do gram stains all the time. You see a gram-positive coccus, oh, this patient probably has Streptococcus pneumoniae causing meningitis. Let's begin antibiotic therapy to treat that particular infection. So that type of rapid diagnosis is really important for things like meningitis. If you have more time, let's say it's pneumonia and the patient is relatively stable, maybe you could look for the particular polysaccharide. This is group C strep, or you could do PCR. But when you don't have time, what can you do really rapidly to try to diagnose the infection? So antibiotic therapy should be started right away, especially in bacteremia and meningitis. And you'll want to jump to something like vancomycin or ceftriaxone because we do see a lot of antibiotic resistance in this species. So we see resistance to penicillin, to a group of antibiotics called macrolides, and to cephalosporins. So as the clinical laboratory professional, maybe you'll be in the lab testing for the resistance profile of the organism, but the physician should be starting some type of antibiotic therapy right away, and that's where I would start. But we have this wonderful tool that can also help prevent infection called vaccination. So this is the pneumococcal vaccine. It is given to children and elderly people because, again, they're at more risk. So it's a standard vaccine as part of the childhood panel. If you were a little bit older and the vaccine did not exist when you were a child, you can get it when you're elderly. So we've seen some of these figures before from the CDC about antibiotic resistance. So erythromycin resistant group A strep is considered to be, they call it their threat level concerning. They have 3 levels of threat, concerning, serious, and urgent. We haven't gotten to urgent yet. Urgent will be fun. So this is concerning. 5,400 cases in 2017, 450 deaths. Clindamycin resistant group B strep, remember this is the pregnant women and neonates. 13,000 infections, 720 deaths. And drug-resistant Streptococcus pneumoniae, we've gone up in level of threat, serious threat, 900,000 infections, 3,600 deaths. So, sometimes people think, oh, strep throat, that's such a common childhood infection, but these strep infections can be really serious for patients. Okay. So questions about strep. This is this was their 2019 report. They published a supplement, and I didn't want to put it in because the way they did the supplement is not super well organized, but I'm a nerd and I read the whole supplement. And they wanted to basically look at how did COVID affect rates of antibiotic resistance, and they thought it would actually be lower because fewer people would go to the hospital for other things besides COVID. It's actually much higher. So they're seeing all of these at much higher levels now. Maybe because COVID made them more susceptible to getting other infections. But yeah, so these numbers are actually going to be low. Yeah. Okay. So our final group that's in here, even though it's a different genus, I still put it in with Streptococcus because it used to be Streptococcus. So prior to the development of all these really great molecular tools like sequencing that we have, we based our classifications of microorganisms on their biochemical tests, their gram tests, protein profiles, serology, right, all of that. Now that we have molecular tools, we can tease apart these relationships a little bit better. And so these bacteria that were classically called group D strep, are actually now in the genus Enterococcus. They lack a lot of the other virulence factors that some of the other, like staph and strep, have, including, they do have, though, some adherence. They have some antibiotic resistance. But for the most part, these are going to be more opportunistic types of infection, especially in a hospital setting. So enterococcal infections are important hospital-acquired infections. Really commonly, in the hospital setting, you'll see them as a urinary tract infection because, based on the genus name, what part of the body do you think this infection targets? Enterococcus. GI tract. It's a gastrointestinal organism. And so some of you might have gotten a little bit, I don't know, it's a little bit tricky because sometimes these are resistant to bile salts and can every once in a while pop up on the media that you think should only do gram negatives, like EMB, because it lives in the gut. So it's an important hospital-acquired infection. Gut bacteria are far more commonly associated with urinary tract infections because of anatomical proximity. It's easier for fecal bacteria to get into the urinary tract. They can also cause septicemia. Remember, in our hospitalized patients, they are in the hospital for a reason. And most of the reasons that you would ever be in the hospital will slightly suppress your immune system. Just having surgery, childbirth, other infections, some sort of immune suppression, which can make you more prone to these. And it also can cause endocarditis. So it can cause inflammation in the membranes surrounding the heart and the heart valves. Generally, these infections need to be treated with combined antibiotic therapy because of that antibiotic resistance. Treating infections with combined antibiotic therapy, like 2 or more antibiotics, is one of the best strategies for a couple of reasons. One, let's say you don't have time to actually test whether or not the bacteria is resistant to a particular antibiotic. If you throw 2 antibiotics at it, you're more likely to have picked one that it's not resistant to. The other reason is that, let's say it wasn't resistant before, but you start treating it with antibiotics and it begins to develop resistance to one, you can still wipe it out with the other. So combined antibiotic therapy is good for helping to slow the evolution of antibiotic resistance as well. And the reason that we often have to do combined antibiotic therapy is because of this thing here, VRE, vancomycin-resistant Enterococcus. So vancomycin is considered to be a pretty strong antibiotic, pretty good cell wall inhibitor, and there are lots of Enterococcus strains that are resistant to that. So here's a enterococcal endocarditis. So you have a 40-year-old man who has hepatitis C, high blood pressure, and end-stage renal disease. So he's got problems. And he developed fever and chills during dialysis. That's to treat the renal disease. In the 2 months before the episode, he had been treated with ampicillin, levofloxacin, and gentamicin for group B Strep. So he had a Streptococcus agalactiae endocarditis. Cultures performed during hemodialysis grew Enterococcus faecalis that was resistant to levofloxacin and gentamicin. So he's got a multi-drug resistant Enterococcus. Because the patient had an allergic reaction to ampicillin, they treated him with a different antibiotic. When they did an echocardiogram, they saw that he basically had biofilm that had formed on his heart valves. That's what that means, vegetation. Like there's visible growth on those heart valves. Over a 3-week period, his heart output deteriorated. So they desensitized him to ampicillin. When patients have an allergy to a lot of different things, you can medically basically expose them to the antigen so that they won't have an allergic reaction anymore. Sometimes people who are allergic to cats but are cat ladies will do this so they can still have cats. But you can do this for antibiotics as well. So they switched to ampicillin and streptomycin. After 25 days of hospitalization, they replaced his heart valves, so they gave him artificial heart valves, and gave him 6 more weeks of antibiotic therapy. The use of broad-spectrum antibiotics predisposed this patient with previously damaged heart valves to endocarditis by Enterococcus, and treatment was complicated by the resistance of the isolate to many commonly used antibiotics. So what can happen is these broad-spectrum antibiotics, broad spectrum means they target lots of things. They don't always target the thing that you want them to target. Your whole body, your whole microbiome is seeing these antibiotics. And so sure, maybe it treated his group B strep, but the Enterococcus that was living there was like, ooh, excellent, I am learning, right? And evolving. And it evolved resistance. So it's important when you have patients that have a bacterial infection, you want to do the best you can to prescribe as targeted a therapy as possible. Sometimes you don't have a choice. You've got to throw the broad spectrum antibiotic. Your patient is septic. Your patient is dying. Your patient has meningitis. You do what you can to save that person's life. But, when a person is on this prolonged antibiotic therapy that is broad spectrum, that provides its own risks. So it's something that you as the clinician, when you're thinking about what you're going to prescribe, you as the laboratory professional, when you're looking at these organisms and making recommendations, that's what you have to think about. So the CDC considers VRE, vancomycin-resistant Enterococcus, to be a serious threat. Over 50,000 hospitalizations, almost 5,500 deaths, over $500 million in attributable healthcare costs. So it costs the patients like that much more money. Okay. Questions about Enterococcus. One of the other things that we start to see in clinical settings, remember we talked about MRSA? So we have methicillin-resistant Staph aureus. We have vancomycin-resistant Enterococcus. They can exchange genetic material, and you now have things like methicillin and vancomycin-resistant Staph aureus. So not only is it dangerous for one species or one genus to carry resistance, they can then spread it to everybody else. So antibiotic resistance can be a really dangerous thing to have be established in your clinical setting. So in your hospital, in your office, you don't want this because it can get bad very quickly.
So 5,400 people died per year?
In 2017 of that infection.
Just like United States or?
In the United States only. Yeah. Worldwide, the numbers are much higher. Yeah. I think worldwide right now, it's something like 1 or 2 million people a year die of antibiotic-resistant infections. And they think if we don't develop new antibiotics by 2050, 10 million people a year will die worldwide of drug-resistant infections. And that's more than die every year of cancer. So just a bacterial infection is going to kill you when, for a long time, it didn't. We used to have a really good chance of fighting them off.
Why is it that with some bacteria they have to drink like the antibiotics for like a longer period of time compared to?
That's a very good question. So the question was, why do some infections or why do some patients have to take antibiotics longer than other patients or other infections? So for bacteria that are very slow growing, that's when you'll see a really extended period of prescription, because the majority of antibiotics only work when a bacterium is actively dividing. So they will inhibit the bacteria's ability to build a cell wall. Well, the bacteria is just sitting there not building a cell wall, it doesn't matter. But as the bacteria grows and tries to replicate and build new cell walls, then it has an effect, or replicate their DNA, or synthesize new proteins. So all of these drug targets are really only available as the bacterium is actively metabolizing and growing. So when you have, these are pretty fast growing. So a normal patient will take antibiotics for maybe a couple of weeks to clear up something like strep throat or pneumonia. But patients who are immune compromised, they usually take antibiotics longer as well, because in an otherwise healthy individual, the antibiotics and the immune system can work together to clear the infection. But if a patient is immune compromised, you're really just relying on the antibiotics. So they're really slow growing, and then your patients that are immune compromised will need extended therapy. And when we talk about some of the fungal infections, patients who are immune compromised, like HIV patients, if they get a fungal infection, they usually have to take the antifungal for life because they can't clear the infection. Any other questions? Okay, so what I'd like for you to do now is get into 3 groups. So you pick your friends. Be in 3 groups and so I'll give you like a minute to get in your groups, and then take 5 minutes to answer these questions. And then with the last couple of minutes of class, I'll pick on one group to answer each question. Okay, and if somebody wants to like write the answers down and turn them into me, or you can email it to me, that's fine too. Just record who was in your group. First names are fine. You don't have to do full names. So first names of who was in your group, email me your answers, or you can write them on a piece of paper and give them to me, either way. So go ahead and get in 3 groups. I'll give you 1 minute. I'm always your timekeeper. I'll give you the 1 minute, and then make sure everybody gets a chance to participate in how you're going to answer these questions. 3 groups overall, yeah.
She can write down, or I can write down.
Who wants to write down? I mean, like sometimes
Are we turning it in online?
It doesn't matter. You can either email it to me electronically or you can turn in a piece of paper. I don't care. Either way, whatever's more convenient for you.
Professor, do we have to write down the question or just the
Just the answer's fine. Yeah, you don't have to write down the question. You can just write down the answer, and you can do it electronically or on paper, however you want. So you have just like 4 more minutes to answer the questions. It's like Jeopardy, right? Do, 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 do.
Oh, just answer.
Yeah, just the answers is fine. Yeah, you'd spend the whole time doing the questions. Yeah, just the answers. Oh, and the lingula is like this little projection that's only on the left lobe. If you speak one of the Latin-based languages, it's like it's a tongue. It looks like a tongue. So there's a little like tongue-like projection only on the left lung. So that's what they're talking about there, that there was infection in the little lung tongue. And I can clarify anything for you if you're not sure.
Yeah.
That's the answer.
Like respiratory disease? Yeah, respiratory disease. Because the man that had the infection, wasn't he have like, oh no, was the lady, she had cancer? Yeah.
Like 2 more minutes.
Oh my gosh.
Pressure. You get full credit for doing it, so even if you like don't get all the way to the end, it's okay.
Meningitis.
Yeah. Meningitis, bacteriemia. Yeah. And that's all for the first one. Yeah.
And whatever major variants
Would it be meningitis? 'Cause I
For
know.
two?
Yeah, because
Yeah, meningitis.
pneumonia and agalactiae cause meningitis.
Yeah, meningitis.
Pneumonia, bacteremia.
Bacteremia, faecalis.
Yeah. Three.
Yeah.
Right?
Those are the, all those three have those two.
What are the major ones? Okay, so the AJ protease for LAI.
And that one is
The first one.
because
All right.
NF protein.
So, what predisposing condition made this patient more susceptible to pneumonia and bacteremia? Right here in the front. What did you come up with?
Pulmonary disease.
His pulmonary disease. So this patient was more susceptible to the respiratory infection because he had chronic obstructive pulmonary disease, COPD. What other populations of patients are susceptible to this type of infection? Immunocompromised. Who gets the vaccine? Children and the elderly. Very good.
And maybe pregnant women too?
Not this one. Not this one. But yes, we'll get to pregnant women. What other infections does this particular organism cause? Besides just pneumonia, what else can it do?
Meningitis.
It can do meningitis,
Bacteremia.
bacteremia. Yep, good. What infection is caused by Strep agalactiae, group 2 in the middle?
Impetigo and group A strep.
For group A strep. Yep, how about the second one? How about group B?
S. agalactiae,
Uh-huh. What does that one do?
bacteremia, and pneumonia.
In what patient population are we most worried about?
Pregnant woman?
Pregnant women and the babies, the neonatal, right? So strep pyogenes, it can do the impetigo, it's the group A strep. It can also cause strep throat, and in some people, they're very unlucky and they get necrotizing fasciitis. And then what infection do we typically see with S. pneumoniae? Bacteremia, pneumonia, in some cases meningitis. All right, last group in the back, group 3, what are some of the major virulence factors we see with some of these different species?
For like Streptococcus pyogenes, it's like beta hemolytic.
Uh-huh.
Has the M protein, F protein capsule, which help evade and immune responses. Has toxins,
Uh-huh.
the exotoxin, streptococcal pyogenic exotoxin. Some of them are like alpha hemolytic, but it's not that bad. But there's other one where other virulence factors.
Mhm.
It's antibiotic resistance.
Oh, yeah.
That's a big one.
And what about strep pneumoniae has one that was kind of unique to it that helps immune evasion? IgA protease. Yeah, very good. Cool. So those are the types of things that you'll need to know about the bacteria. You might think about what could complicate treatment, what could complicate and predispose patients to infection. Sometimes we might have a case where I don't tell you what the infection is, and you might have to try to predict the infection based on maybe some test results or something like that. So these are really good, I think, to help you guys really start thinking about what these organisms are doing. And again, as we progress through the semester, I really want you to think not just about each organism by itself, but what organisms cause meningitis? What organisms cause necrotizing fasciitis? How can you treat them? How can you tell them apart? What are the differences? Okay? So if you did it electronically, just email it to me. If you did it on paper, turn it in. Otherwise, have a great weekend. I'll see you all on Monday.
Are we going to the lab to look at the
Oh, yeah, we got to go to the lab and look at the, what is it called? Oh, yeah, before we go away for the weekend, if you have time, we'll go up to the lab right now and see if all of you have nasty teeth. Did you guys do the chewing thing?
Yeah.
No, some of you did. Were you like a little bit like, ooh? Oh, okay, good. You have good brushing habits. Excellent.
I left late in the morning.
Uh-huh.
I was like,